Thank you, Dr. Bellini, for that very fitting presentation. Thank you, thank you. I just going on the heels of what Dr. Bellini said, there is information coming up, and I did speak to Gulruk, so once that information has been confirmed, everybody here will be getting an email for that updated data and information and communication as well too. So just watch out for that, and of course it'll be posted on our website as well too, so keep an eye on both. Those things are excellent resources, and like I said, we'll be sending that information later on this year. So, okay, now I get the honor of introducing our next speaker, Dr. Mark Monicasi. Dr. Monicasi is a therapeutic endoscopist currently practicing at Mississauga Hospital. He completed his GI fellowship at the University of Toronto, 2019 to 2021, followed by a fellowship in therapeutic endoscopy at UC Irvine. He practices in hepatobiliary disease, including ERCP and EUS, and acts as a local pancreatic cancer screening clinician for the THP system. He also provides care in third space endoscopy, including ESD for advanced resection and POEM for achalasia patients. So please join me in welcoming Dr. Monicasi.
How's this work? Laser? No? Okay. Back. Which one's a laser? That one. Okay. So good morning, everyone. Thanks. That photo is definitely AI generated. I'm nowhere near that handsome. I was forced to do it. So I'm here to talk to you guys today about pancreatic cancer screening. I think you'll see you're probably already doing a great job because there's not much to do, but I'll show you maybe some areas where you can focus on, some nuanced situations where screening is appropriate, and maybe some new things that you can do to alleviate the stress your patients have if they are one of these people that needed screening. So happy to be here today. Unfortunately, this won't be the most fun talk. I didn't have a lot of jokes I could crack about this, but we'll try to make it interesting so you walk away with something. I don't have any disclosures, financial or individual, and I don't think there's much bias in this talk. So really, I just want you guys to walk away today feeling you know who are appropriate people to refer for pancreatic cancer screening, what you can do for them in your office, when to refer, and maybe just how to work with these patients a bit better, because as Andrew alluded to and we'll talk about, there's a lot of stress when it comes to pancreatic cancer. It's scary. I think it's on the top of everyone's mind somewhere or another when they walk into my office with dyspepsia. The first thing they have is it my pancreas? So, I mean, people are really afraid of this, and I think it's because everyone does know someone, at least through a family member or secondary family member that's had something, and they've just seen bad outcomes, which is unfortunate. So in Canada last year, there were about 7,200 cases of pancreatic cancer. As Andrew alluded to, it's the third leading cause of cancer-related mortality, so it fights above its weight class. By incidence, only the most 11th, so very low incidence, but unfortunately very, very poor outcomes. The 5-year survival is only 10%, and that's when you look at the whole cohort of patients. And as you can see, if you look at people with metastatic, regional, or localized disease, you go from 3% in metastatic cases to only 41% in localized disease. So even localized T1, 41% 5-year survival, which was about 50% for colon cancer, as we just heard. So even when you catch people early, the outcomes are not where we want them to be. And unfortunately, the surgery is quite morbid and a lot of complications from that, driving other poor outcomes or quality of life issues. The lifetime risk of developing pancreatic cancer is only 1.5%, so quite low. And because of this, we don't recommend screening the population, as we just don't have testing that's sensitive or specific enough to really detect it. The number needed to screen would be exceptionally high with expensive testing, so we don't recommend screening, which is why it's just not offered here or even in the US. So, you know, if the US isn't doing it, it's really not recommended because they would be the first one to do anything. However, high-risk groups should get screening, and these are individuals with a greater than 5% risk or greater than 5 relative risk compared to the general population. And in these enriched populations, we see that targeted screening does enable earlier stage detection and better outcomes. So this was, I think, Canadian Cancer Society data, the most up-to-date I could find, and it's weird it tailed off at 2019. But you can see for the incidence of the common cancers, breast, lung, colorectal, and then pancreas, you know, there's a big difference in the incidence, as we talked about, 11 versus 1, 2, 3. Which really hasn't changed over time, so it's not going up again. It's fairly stable. But what we see is when you look at mortality, I guess this is changing, I guess, Andrew, but mortality was going down for colon cancer, lung, breast, but pancreatic cancer just never really budged despite better chemotherapy, earlier detection in some instances, genetic mutations. We're just not really seeing the needle move a lot. And that's where I think the beast lies with this, is it's very difficult to treat and get those outcomes for patients. So majority of cancers come through 3 pathways. You can have inherited mutations, which we'll talk about. So these are your Lynch families, your BRCAs, hereditary pancreatitis syndromes, about 10 to 15%. Mucinous cysts, which I'm sure you guys see regularly on your patients going for a CT for something different and a cyst is found, make up about 15%. And then pancreatic intraepithelial neoplasia, or PANNs, are the main driver. So what are PANNs? They're like the polyp of the pancreas, except we can't see them or identify them. So within the main duct of the pancreas, you have the epithelial lining, and there's essentially a transition through a PANN1, PANN2, PANN3 until you get a carcinoma. So it's a ductal process similar to like in colon cancer where you have a polyp to adenoma sequence. They can be identified on imaging. So in these high-risk individuals undergoing screening, PANN3s, where you're starting to see an actual structural change, will be seen on imaging. So they are certainly identifiable. The problem is we don't see them on general patients because they're small, they're asymptomatic, and they have time to grow. So what are the main non-genetic risk factors? Tobacco use, chronic pancreatitis, obesity, diabetes. If your patient even has a combination of these, they're still not high risk. So it's not like it's a checklist. Your patient can have all of these. They're still not a high risk individual for screening, but they should definitely be educated that these are all major risk factors, and a lot of them are intervenable or optimizable, apart from probably chronic pancreatitis where we have to manage symptoms for the most part. I want to take a moment to talk about fatty pancreas. I think this is something new and only starting to get attention. I did my fellowship in 2022. I remember the first time I saw fatty pancreas on ultrasound. It was this bright blob. I had no clue what I was looking like. I called my staff into the room and he just goes, "Oh, fatty pancreas," and walks out. Okay. So even in 2022 at an academic US institution, no one cared about fatty pancreas, or at least for the most part, but it's starting to get a lot more attention. And the data is poor. I will say it's all retrospective cohort studies. There's no randomized trials. Like, this is still emerging, but it's felt to be an independent risk factor for pancreatic cancer. Mechanisms include the tumor microenvironment changing, chronic inflammation similar to our NASH patients with liver disease, and autophagy dysfunction in the level of the area. And what they see is that even when you correct for people with fatty liver, metabolic dysfunction, diabetes, obesity, independently, it's a significant increased risk for pancreatic cancer at almost odds ratio of 2. And it's been found to be detectable up to, 3 years before malignancy development. So when they look at retrospective cases, fatty pancreas is showing up on imaging 3 years before cancer in these populations. So I think it's an area that will have a lot more research going into it. I'm not saying it's something you need to scare your patients about when you see it, but I think it's something to keep in your back of your mind that this is just not normal or something that really should be fully ignored. So some of the more recent studies looked at this. This was a US study, retrospective, looking at CT-based fat. Fat's usually showing up better on MRI or endoscopic ultrasound, but if you do a dedicated CT study for fat quantification, then it can be seen well. And what they see is intrapancreatic fat, 26 versus 4.9%, with controlled liver subcutaneous visceral fat compared to control. So everything else normalized out. Significant increased attacks of acute pancreatitis, chronic pancreatitis, 6%, and pancreatic cancer, as well as increased amounts of cysts, so driving a different cancer pathway for development. And again, there was no incidence of extrapancreatic malignancies. So there's legit signal here, I think. This was a UK biobank study where they looked at 50,000 individuals. They teased out normal versus fatty pancreas, and at the bottom, it's by the quintiles. So this purple line is the highest amount of fat. So you can really see when you tease out the difference in fat quantification, you probably need to reach a threshold where amount of fat is actually leading to a difference, at least at the lower end. But again, significant increased amounts of acute pancreatitis, pancreatic cancer, diabetes, and then all-cause pancreatic disease. So I think it's something, if you see on your patient's scan, to keep in the back of your mind. Probably, I wouldn't say you need to image these people or do anything aggressive, but if they are developing symptoms or something's changing as you move forward your care with them, I would have your threshold to do something maybe at a bit lower level. So who are the high-risk pancreatic cancer populations that really screening is recommended for? These are individuals with the genetic susceptibility. pathogenic germline mutation, or a unique familial clustering that puts them again above that 5% threshold. So lifetime risk greater than 5%, and there's some syndrome-specific elevated risks which may get people to be considered even if they don't always reach this 5% cutoff. Screening's done via imaging. MRI is one method. It's advantageous as it can detect small cysts and subtle parenchymal changes better. There's no radiation exposure and it's non-invasive. The other common modality is endoscopic ultrasound. So it would be an endoscopic procedure, a bit more invasive for the patient, but generally very limited, no prep required. It allows for very high spatial resolution, so you get a very close-up look of the pancreas. You're less than a centimeter away from it. You get very fine details. It's better for identifying small solid lesions, and also allows you to biopsy at the time of the procedure, so potentially you can do everything in one setting. Generally, these are complementary, so one is not better than the other. In screening programs, we alternate, so an MRI or ultrasound would be done yearly, every other year for each one. And the sensitivity specificities are around the high 80s, mid 90 range. So again, not perfect. Things can and will be missed, unfortunately, but it is the best way of screening we have available to us right now. So the general pathway, I guess, of a patient's experience would be they're identified as a high-risk individual. This could be from their own cancer diagnosis where they have genetic testing done and they're found to be a BRCA or a Lynch carrier. They could have a high-risk family history or family members diagnosed with a mutation themselves. They usually end up seeing a genetic counselor, possibly having genetic testing done, confirming they are of high risk for pancreatic cancer. Surveillance should be initiated then based on the specific age. We'll go through some of these. You can see there is some variability in when you should start and stop. Again, annual MRI and endoscopic ultrasound. If a lesion is detected, so a cyst, a pannin, or a tumor itself, they should be discussed at multidisciplinary review. Intervention should be then offered if appropriate. Those individuals then need to resume screening, so they're never really done, right? I mean, they'll usually have partial pancreas remain if they get a Whipple or distal pancreatectomy, so screening does need to then continue in these individuals up until the point where around, we say, age 75 or 80, or an unfit surgical candidate, or the patient makes a decision that's no longer really within their goals of care. So the goals of screening, again, trying to detect precursor lesions. These are your PANN 3. Cystic lesions with high-grade dysplasia, which are really difficult to tell on imaging. I mean, we see very large 4 or 5 centimeter cysts. I sample them and they come back as completely benign. Some end up going to surgery with nothing found at all. So finding dysplasia is very difficult. We'll talk about cysts briefly as we go forward and see some things that are a bit more high risk, but again, imaging alone is only so limited. And then ideally detecting localized tumors, T1, that give you the best option for intervening and having a positive outcome. So some of the high-risk populations, the first is familial pancreatic cancer syndrome. These are greater than 2 first-degree family members with pancreatic cancer. They have to be first-degree, second-degree does not count. There's no identifiable germline mutation in them, so the cause of this is really undetermined at this point. If a patient has 2 first-degree family members, they have about an 8 to 12% risk versus 3 or more up to 40, so quite significant. This is probably one of your higher risk syndromes. Screening is recommended at age 50 or 10 years before the youngest family member that had pancreatic cancer, and again with alternating MRI or endoscopic ultrasound, again until the point where they don't want to screen or are not an appropriate candidate for whatever reason that may be. Peutz-Jeghers syndrome, this is a autosomal dominant mutation in STK11 gene, which encodes a tumor suppressor, so increased activation of growth, unfortunately. Classic features are mucocutaneous pigmentation and a report of hamartomatous polyps. They actually may present with this finding first because these polyps can obstruct the stomach, the small bowel, the colon, and when they get removed, they find these on the pathology. The mucocutaneous pigmentation is usually more common when they're younger, and it actually fades with age. It's usually around the lips, the buccal mucosa, and it can be pretty subtle. The risk is quite high, again, close to 36%. Screening is recommended starting very young at age 35. As the patient goes, their lifetime risk of cancer does increase, unfortunately. These are just some pictures of what it looks like. Again, it's quite subtle on the inside here in some of these cases or around the mouth. So if you do have a patient with this and a degree of suspicion, but again, this is an autosomal dominant mutation, so someone in the preceding generation should have a history of something as well. So the family history is really important here. Of course, an individual may present as the first one in their family if family history is unclear, but there should be a yearly family member because they're getting a 50% chance from the family member of getting this. So family history is important to help guide your decision, I would say here, but always can refer for a second opinion if needed. Hereditary pancreatitis, also very high risk. These are usually mutations in the PRSS1 or the SPINK1 gene. Cystic fibrosis, also big cause of chronic and hereditary pancreatitis. Maybe some of your patients have that, but it's not as high of a risk factor for pancreatic cancer screening, so your CF patients usually don't need to be screened. It causes early onset recurrent acute pancreatitis, so usually they have their first episode as a child, and genetic testing is eventually done and they get found. Because of the recurrent attacks, these people are at very high risk of developing chronic pancreatitis, which is where the risk of the malignancy comes from the chronic inflammatory change. PRSS1, again, is a autosomal dominant, whereas SPINK1 is a bit trickier. It's not autosomal dominant or recessive. It's probably more of a tumor modifier, kind of influencing the whole genetics of the person in some degree. So testing for that is a bit more difficult to pinpoint. Risk quite high, up to 50% by age 75, and again, it's more so from the early inflammatory change that's going on. Screening is recommended around the age of 40, so again, quite young, a bit older than your Peutz-Jeghers syndrome, but still younger than general, BRCA or Lynch syndrome population. FAM syndrome is familial atypical melanoma syndrome. I think there's another M. It's the mutation, the CDKN2A gene. They present with multiple atypical nevi, and they're very atypical, lots of different, forms and appearances. There's a family history of melanoma. The melanoma could be in a first or second degree, so it's a bit more broad in that aspect of things, but it's also autosomal dominant, so there should be a direct family member in the prior generation who had something that can, help guide you. Risk is still quite high, up to 20%, so we start screening around age 40. And it's always recommended, again, with annual MRI and ultrasound alternating. This is just a kind of classic picture for what they may show like. A lot of different types of nevi. I'm terrible at dermatology. I would just refer someone to derm if this patient came to my office to confirm and then have the family history, because I would not be able to make this call. But again, the family history of melanoma is probably what's going to guide you, and probably more than one generation having melanoma, grandmother, mother, father. And that's really the takeaway I would say from them. So you're still important, but likely lower threshold for having pancreatic cancer, and patients that you'll see a lot more. So BRCA1, BRCA2, ATM mutations, much more are going to show up on testing. The incidence is a lot more common, but the risk of cancer is a lot lower. So I would spend time with these patients when they're in my office trying to explain that to them. They are very stressed when they come in. They usually are detected after having breast cancer or endometrial cancer or something else, and then they get genetic testing done and they're told they have a risk for pancreatic cancer. So the anxiety is through the roof when they come into my office. I spend most of my time just trying to explain what the true risk is, try to tease out the differences, as there are some differences between BRCA1 and BRCA2 and overall risk, and explain to them that, they will be okay, and that screening, again, in some instances, may not always be recommended. Now, I haven't had much success in convincing someone not to undergo screening. I do talk to them about it, but I can certainly understand why someone wants to do everything they can when they're showing up midlife with this finding. And who am I to defer someone having an MRI or an endoscopic ultrasound? So I generally have never declined, screening to somebody, but I do explain that it's not something I want them losing sleep over or stressing. So these are DNA repair pathways. They're often again identified via hereditary breast ovarian cancer testing after they present with this, or again, if there's a family history, they may get referred directly to genetic testing. But you can see the risk is a lot lower. For BRCA2, it's 5 to 10%, so you're just meeting that threshold. The BRCA1 risk is even lower, and if you look up all the different GI societies, the NCCN in the US, BRCA1 actually doesn't even meet the threshold of 5% for pancreatic cancer screening. It was more likely included just because they had no way to say to a BRCA1 patient, you can't get screening, I think, because they really stress they should have a family history, and even then a strong family history. And again, they do not meet their cutoff criteria, but it's still recommended to screen. Your BRCA2s, generally no family history required. Your BRCA1, a family history is usually recommended. I've never deferred screening to someone because of no family history, again, because of the stress, and just making them feel better is really important in these situations, I think. Starting age is later, so age 50 or 10 years younger than family history. So because of that lower risk of cancer, we can delay things a bit in them, which is beneficial. So again, stronger evidence for BRCA2 versus BRCA1, lower absolute risk. Screening should be individualized. I have the conversation, but I don't push it on them. Everyone's free to make their own decision, and we're here to support them. but certainly a lot of variability in the guidelines, and it's a shared decision making, but if the patient values screening, then I think we're there to support them. Lynch syndrome, another common one that's going to show up probably in your office, mismatch repair deficiency in MLH1, MSH2, and MSH6. Your MLH1 patients are the higher risk ones. Overall, across the board, about 5 to 9% risk. And again, many colorectal extracolonic malignancies, pancreatic, kidney, uterine. Screening is recommended if there is a family history. So again, I really do try to emphasize to them they're probably not meeting threshold criteria if they're not having a family history. But again, if someone values screening, I do offer it to them. It's difficult as we're trying to be judicious with resources and not overscreen, but at the same time, when you have the individual in front of you, we have to treat them. Sometimes I do talk to them about starting off screening, stopping early, or extending screening, but there's no real guidelines or evidence for that. It's kind of just me trying to work with them to make them feel happy in a way that still supports what the evidence shows is appropriate. We don't have to go into this, but again, older criteria for Lynch syndrome, we don't really use these anymore. Most of these are just detected based on direct genetic sequencing. I think in some instances, Amsterdam criteria, which is your 3-2-1 rule, 3 relatives, 2 generations, 1 younger than age 50, does apply if they don't have confirmed genetic testing done. So if your patient actually has Lynch mutation, not germline, you could rule them as a Lynch syndrome with Amsterdam criteria applied. So it's still worthwhile, I think, knowing this one. I think Revised Bethesda's in the dust, and we have just better access to genetic testing to confirm this now. But I would remember this one, again, because some situations it may pop up, just so you don't miss a situation. So, in summary, we can group these into our lower and higher risk groups. So your low to moderate risk are your BRCAs, your ATMs, your Lynch syndrome. Again, roughly around 5%. Screening, again, recommended generally with at least a family history in most of these situations. The guidelines would say for BRCA, 2, you don't need the family history. And then your lower second degree to first degree family members for familial pancreatic cancer syndrome. So again, starting closer to age 50 or 10 years younger. Your higher risk situations are your familial pancreatic cancer syndrome with 3 or more relatives, your hereditary pancreatitis, your FAM syndrome, and Pew-Sager. Again, significantly higher risk, usually starting at age 35 or 40 with no family history required in these situations. So again, similar graph. This is what I actually show a lot of the patients coming in, that the incidence or prevalence of these other mutations are much, much higher, with the risk of pancreatic cancer, much lower compared to these other syndromes. So seeing that does help them understand a bit. I still never convinced one person, but I try. So I did not want to talk about pancreatic cysts. I think it's impossible in this talk to talk about cancer without pancreatic cysts. I can talk about pancreatic cysts in detail if you guys want to go down the rabbit hole another time, but they're just a scourge on us, I would say, right now. People go in for your CT for a kidney stone, whatever else it is, and a 9mm cyst is seen in the pancreas, and then you start them down their threshold of screening, and then you think they're okay, and then at year 5, just when you're about to say you're fine, it grows 3mm, and then you restart the whole sequence again. So we're just inundated with cysts, but in the appropriate population, the appropriate cysts, we do need to follow them. It's just when to stop screening has become this battle that no one's really ready to take on, because the fear of you dismissing someone with a cyst and them showing up a few years later with a cancer that you could have maybe prevented. So there's many types of cysts. Your serous cyst and your pseudocysts are your benign group. So serous cystadenoma, more common in females, 5th to 7th decade of life, honeycombed appearance with a classic central scar on imaging. If those are all commented on, they really shouldn't have any more screening. I mean, they have no risk of progression to cancer. The problem is other things can look like a serous cyst, so even the serous cyst gets followed. But generally, this is a low-risk malignancy. Your pseudocysts usually are coming in the setting of recent acute pancreatitis, developing after that inflammatory response. Those can be managed, drained, left alone. They're not going to become a cancer. Your mucinous cysts are the ones that are the problem. So these can be your isolated mucinous cystic neoplasm, and then your IPMNs with your branch duct and your main duct involvement. Pseudopapillary neoplasms are their kind of own group. Again, those are usually always dealt with surgically if detected and confirmed because of the high risk of cancer. So again, 15% of all cancers will come from cysts, which is a problem because there are a lot of them. The prevalence is close to 15% in asymptomatic individuals, so that's a lot of cysts in a lot of people. Thankfully, the majority are small, smaller than a centimeter, don't grow and, potentially could be stopped from screening if, after enough time, you see no growth and stability, because patients in their own way sometimes do get tired of all the testing they're going through. Surveillance is recommended for any mucinous cyst, your IPMN, your MCN. There's a lot of heterogeneity between the guidelines and uncertainty about when to start, when to stop, and how frequently. Radiologists have their own opinions, so the radiologist will put on the bottom of the report and this time, and then the GIs will have all their own opinions. So, these are situations where if you're unclear, refer to me or someone else who looks at these, and we can sort out what's going on and figure out the best path for the patient, because I think you will get a different comment from me versus the opinions and the guidelines I use versus a radiologist. I'm not saying one is better or wrong, but this is what's causing all the confusion. And it's, as I mentioned briefly, it's putting a lot of burden on patients, healthcare resources. A lot of these patients won't have cancer, but then you detect a cyst, and again, they're scared because they have someone that had a family history of pancreatic cancer, and now they have a cyst. So it's causing a lot of anxiety out there, I would say. The important thing to note too is that there's a field defect with pancreatic cysts, so irrespective of the cyst, the whole pancreas needs to be evaluated. It's at risk. You can get concomitant malignancies, 1 centimeter cyst in the head, cancer shows up in the tail. So the whole pancreas has had some sort of functional or genetic change in these individuals, and that's what makes screening them and treating them even difficult, because as you can imagine, if you have a distal tail pancreatic cyst that develops a malignancy, they get distal pancreatectomy, the remainder of their pancreas is still under threat. So do we screen them? Do we not? No one really knows. So the risk of progression is significantly different. Your main duct IPMNs, they're the scary ones. Usually the duct is dilated above 1 centimeter. You can see mucin actually when we do an endoscopic ultrasound or ERCP coming out of the duct. And if you have a main duct IPMN, the majority should be referred for hepatobiliary assessment and surgery, I would say. Your branch ducts, they can have higher increased risk as size increases and worrisome features start to show up. So again, for a branch duct IPMN, probably about a 7% chance within progression to cancer in 10 years. For those that are hitting the worrisome features, that's not all cysts, but for that purpose. For high-risk IPMNs, that changes to about 10 years. 25% in 10 years. So a big difference in cysts based on what criteria are present. So these are the Fukuoka consensus guidelines. These are what I would feel most gastroenterologists that manage these would go by in terms of identifying what's a high-risk issue, what's a worrisome feature, and then how we treat them. So, if your patient's showing up jaundiced, a big mural nodule in a cyst, or the duct's dilated above 10 on a CT or MRI, very worrisome. They should probably be seen a surgeon, and they're probably going pretty directly to surgery. They may get an endoscopic ultrasound if the surgeon wants to be sure, but those are very concerning features because you're starting to see a solid structural change. It's just not a fluid cyst. If not, you look for worrisome features. So again, a larger cyst, smaller nodules, rapid growth compared with time if this is something you've been under following. If any of those are present, then they should be referred for an endoscopic ultrasound where we're trying to confirm a couple of these or take a sample to, again, detect malignancy. The yield on FNA is very poor. The majority of these are fluid-filled. We suck out some fluid, but it's very difficult to sample the epithelial lining, but we do hit it sometimes, and it can be helpful. If those are present, again, referral and discussion with surgery about the benefits of surgery. If not, you're kind of just going by size. 1 and 2 centimeter cysts, I really don't get too excited about. It's when you're closer to this 2 and certainly 3 or above range. Again, discussion of upfront surgery should probably be had. But again, you can have surgery done, large cyst, benign pathology, and it's a big surgery. So it takes a lot of discussion between me, the surgeon, the patient about really what they value and what their goals are. So again, what do we do post-resection? Repeat pancreatectomy rates range from 1 to 10% in the first 3 years after people go in surgery for cysts, so they're not in the clear, unfortunately. Some experts recommend 3 to 6 month intervals for the next 2 years, followed by annual screening forever. So again, they're going to be committed to a pathway of ongoing screening if optimal healthcare is the pathway they're choosing to follow. So it's something that hopefully with more time or better testing we'll be able to tease out and separate higher risk from lower risk. So what's the evidence supporting surveillance, overall in our patients with the high-risk syndromes? We talked about cyst. We don't have any randomized controlled trials. Really, this is cohort studies. The majority of this has been from the US. There's a big registry run out of Johns Hopkins called the CAPS, Cancer of the Pancreas Registry. and they work with a lot of the academic institutions of the US to share information on patients, and that's where we take a lot of the data of what's been found, what's the risk, and how are we doing with high-risk screening. We do know from these studies that surveillance-detected pancreatic cancer has significant improved survival. The best outcomes are at experienced centers, ideally, more so in the US it applies. The number needed to screen in these enriched populations is still about 135, so it's not that common. Even with these big long-term studies, there's not a crazy amount of cancer showing up, which is a good thing. So for the whole CAPS cohort, when they're looking at all their patients, they found that they can detect stage 1 cancer in close to 75% of their patients. That's about 20% in the general population. So you've shifted the disease a lot in terms of the stage you're detecting for. They're detecting asymptomatic people earlier, and that's a big deal because the minute a patient presents with symptoms at any stage, so a T1 cancer any stage, 80% inoperable. So you really have to detect people early because symptoms are going to be a poor outcome. There's usually some sort of vascular involvement, and that's the problem. The bile duct obstruction, not usually the issue, but it's more there's vascular involvement the minute they're symptomatic to some degree. They find surveillance detected 5-year survival up to 70%. So again, we had 40% in the general population. At T1, if it was local regional, we were down to 15%. And there's much more improved resectability in these cohorts. So again, we don't have to go too much into this. They've teased it out. Essentially, since 1998 was their whole population, and most recently, when they published their data, was from the 2014 to 2021 cohort. So they had about 1,400 patients in this group. They had 10 cancers diagnosed, one diagnosed 4 years after dropping out of the study group. Of the remaining 9, 7 had stage 1, 1 had stage 2, and 1 had stage 3 of the disease. And 7 of the 9 were alive after a median follow-up of 2.5 years. So, screening is shifting disease, a lot more showing up in stage 1, 2 versus stage 3, 4 compared to the general population, which is where these improved outcomes are coming from. This is again the same thing when they look at screen-detected pancreatic cancers, cancer outside survival, and then screen-detected high-grade dysplasia up here. We're just seeing significant prognosis improvements with survival for those undergoing screening surveillance programs. So it does work. It takes a lot of screening, and it does take a lot of selecting the right patients for this. So once you stop screening, if the patient's no longer a fit surgical candidate, there's no point in ongoing screening. We're not proving anything in that situation. Usually they recommend around the age 75 to 80, similar to our other screening programs for colon cancer, et cetera. That seems to be the number. Obviously, this is individual. If you have a fit 85-year-old and they're appropriate, I've certainly seen them have Whipples offered and done. And I think the patient is what you look at. Usually reassess annually with them what they want to do. Obviously, in a younger individual, they'll probably want to continue for a period of time. So who not to screen? So probably this is where this is most helpful for you guys. So your average risk patient, you don't need to screen. If they're a smoker, if they're diabetic, if they're overweight, if they have chronic pancreatitis, if they have all of those together, they do not need screening. Chronic pancreatitis with one family member who had pancreatic cancer doesn't need screening. So I know these patients do get a lot of concerns. I still don't offer these patients screening. I think the data is strong enough in those situations that I personally don't screen chronic pancreatitis even with one family member. If there's multiple family members, a bit of a different story, and certainly if there's 2 or more, as we spoke about, they're getting screening automatically. But I think that's where a lot of people do think they should have screening done. I have seen some people get screening. Again, it's up to every individual if they want to offer that, but the data would not support it, so I think you stand appropriate if you're not referring for screening in that situation. So what are some of the harms of screening? Anxiety gets mentioned a lot. I think most of the studies have actually shown anxiety is reduced when patients are in a screening program. They feel better knowing they're getting checked. So I think this is probably cited as something, but I don't think the data supports it. Certainly there's some injury related to the screening procedure. They can get pancreatitis when I sample the pancreas if I see a cyst or a lesion. The incidence of an injury or perforation or bleed from the scope itself is very, very low. Certainly contrast risk from an MRI is feasible. Very uncommon, but it's not 0%, but again, I think worthwhile and low enough we should be offering it. I think the morbidity and mortality associated with pancreatic resection is the big one. I think the mortality rate's 2% after surgery. Morbidity can be bad. They can have symptoms chronically afterwards, usually digestive issues, malnutrition, weight loss. It's a tough surgery for them to undergo, so it's something that does take them a lot of time, sometimes if convincing them to undergo it. And then there's possible resection of uncertain benefits. So they undergo surgery for something benign, or there was actually nothing there, some sort of imaging artifact. It's been reported, and those are unfortunate outcomes. So what can we do in clinic and what can you do to help our patients? I mean, they should all stop smoking. I mean, 100%. Smoking is a major risk factor for acute pancreatitis, which is going to cause them their own world of pain. But certainly for pancreatic cancer, this is something they should all do. We need to manage our metabolic syndrome patients well. Our patients with MAFLD or our patients with fatty liver or fatty pancreas. Again, I don't have anything I should say you should do in these situations. I think we know that it's there. We appreciate it. If a patient's showing up with atypical findings for them, especially if they're showing up with new signs of diabetes in a patient that has no other risk factor, so appropriate BMI, healthy diet, never had family history of diabetes, never problems with glycemic control. Diabetes onset can predict pancreatic cancer by about 3 years as well. So an HbA1c annually maybe is not terrible in these individuals. If they're starting to have diabetes despite them exercising and eating well, it could be something is brewing. Again, that's not to scare you or your patients, but the studies have shown glycemic changes do predate by about 3 years. So again, consider an annual diabetes screen. I think it's low risk and can be helpful in some situations. So some future technologies really focus on biomarkers. None of these have been FDA or Health Canada approved. There's circulating tumor DNA, blood biomarker panels, and proprietary marker, algorithms and metabolic signatures themselves. None of these have met sensitivity. They have to be, I think they showed 99% sensitive and specific to be able to be useful for screening because of the low incidence. So it's pretty unlikely something will get there, but it's possible. CA19-9 I see ordered a lot. I would just not order it. It's not useful for screening. It can be falsely low in people with pancreatic cancer. It can be high for completely unrelated issues. It's been studied and it's just not helpful for screening. So I wouldn't do a CA19-9. You'll probably just get a number that confuses you, and then we're going to send a patient down a rabbit hole. So I don't order it. I wouldn't really recommend it if a patient is asking about it. So just want to go through a couple cases just to highlight kind of what we were talking about and hopefully drive home some points. So case one was a 63-year-old male, hypertension, hyperlipidemia, 2 prior episodes of pancreatitis. He smokes, he drinks daily. His father had pancreatic cancer in his 80s, so much later. He came to hospital with abdominal pain, brief admission for symptom control, secondary to pancreatitis. He had a CT abdomen while there, diffuse parenchymal and ductal calcifications, so suggestive of chronic pancreatitis. He shows up to your office post-discharge. He Googled chronic pancreatitis and risks, and now he's asking you what he should do. He heard someone's getting screening. He wants to be screened. I would not screen this person. Again, he's got some risk factors. There's a family member with a late onset, so unlikely anything genetic. He's got chronic pancreatitis, but again, not meeting that threshold for high risk. So I think this is where you just reassure them and, hopefully optimize other things like his drinking and smoking. Case 2 is a 40-year-old female. She has no past medical history, no symptoms, no prior history of pancreatitis, non-smoker. She drinks, family events. She goes out for a night every now and then. Family history, grandmother, breast cancer in her 70s, mother, breast cancer, age 60s. Tumor genetic testing showed BRCA1 mutation in the mother. She's referred for genetic testing, which confirms her own BRCA1 mutation. What do you do? Yeah, I would say screening on family history. By the guidelines, I would just screen her probably, so yes. 50-year-old male, history of hypertension, obesity, seen in the ED for severe abdominal pain. CT reports acute pancreatitis. This is his first episode. Notes made of fatty pancreas by a good radiologist. He smokes daily. He drinks 1 to 2 units daily. He's seen in your office. He's feeling well, weight stable. His appetite's returned, and he's eating okay. You do an HbA1c, it's normal. There's no reported family history of pancreatic cancer. Do you have to do anything? Yeah. Don't screen him, but just optimize his lifestyle. I mean, he's got this fatty pancreas, which I think we'll hopefully get more information about, and we'll see if that changes anything for our patients. But otherwise, he has a couple other metabolic risk factors. We just optimize him and hopefully optimize, outcomes. And then case 4 is a 56-year-old female, history of depression and asthma, chronic GI symptoms of indigestion, bloating, extensive investigations, all normal. She's reporting weight loss. She has an endoscopy, colonoscopy, and CT, all reported as normal. Her father, who was 82, and sister, age 64, were diagnosed with pancreatic cancer. She had genetic testing done that she paid for by herself when she traveled to Buffalo, and it was all normal. There's no family history of Lynch syndrome. She self-pays, again, for genetic testing, which was normal. What do you do? Yeah, so this is your familial pancreatic cancer screening. She's got 2 family members. She's well, no genetic syndrome. She should be screened starting age 50 probably, so you would start her right now. So that's all I got. I think in summary, you guys can see screening is a pretty niche situation. Your pancreatic cyst patients, they're really getting surveillance, so it's not really screening, it's monitoring a known pre-neoplastic condition in the right setting. If you ever have any questions, I'm always helpful. I'm able to help and speak with you guys. You can email me, or if you have any questions, just send the patient along. I'm happy to meet with them. So thanks for having me today. Perfect. All right.
This is a topic we chose based on the feedback we got last year from people that, what do you guys want to hear about? Excuse me. So I'm going to use that as an opportunity to make sure, ask everybody to fill in their evaluations, their feedback, and give us suggestions of what you'd like to hear about next year. Dr. Malignancies, thank you for that excellent talk. I appreciate it. Without any further ado, I'd like to ask Gul to come back up, and as promised, we're going to give you the resources that we have available, our website, and something to take home with you as far as what you want to do. I also wanted to stress that we are available, Dr. Chera, myself, if you want to email us or contact us, anybody at the Regional Cancer Program, and the whole team. So without any further ado, Gul.
Thank you. Thank you, everyone. So I'm the last thing standing between you and the end of the day. So I just want to give you some access to tools and resources to support your practice. We talked a lot about our strategic plan today. I am glad you got a chance to visit the booths and see some of the tools that we have available. So I'll just take you through our website. So this is our website. It's mhcwrcp.ca. The way it's broken up on the So on the right-hand side, you'll see where you can get more information for screening. We have all 4 of our screening programs there: breast, cervical, colorectal, and lung. And all of the tools, any FAQs, requisition forms, contact information for diagnostic assessment programs, hospitals, all are within each of the links under each of the cancer screening programs. There's also sections for diagnosis and treatment and survivorship, so all of our resources are there as well. The healthcare provider resources is a key section, and if you click on that, yes, so sorry, these are the cancer screening toolkits under the healthcare resource providers. So you can see, just as examples, we have all of the resources for First Nations, Inuit, and Métis urban indigenous peoples, and all of the resources are there. We have toolkits. We have information for where you can find documents on symptom management, where you can find cancer services. Many people have come up to me in wellness events and fairs, and they said, what are the Ontario breast screening program sites in your region? All of that is available on the website, where they are, what their hours are, when they can accept patients. All of this toolkit is there as well. So the toolkit that you saw at our booth, it's all here. You click it, you can download all of them at once, and it gives you the option to download them in all 10 languages as well. If you need printed resources for your offices, you just send us an email, and we can courier those out to you as well. Oh, wait, sorry. Okay, so when I click on the cancer screening resources, somebody was asking me about lung. So under lung, we have all of the information. I think it says the importance of lung screening, how to screen for lung cancer, the requisitions, the 2-step process, all of that is right here under cancer screening as well. And if you can see, when I just clicked again, you can see how you can download it in any of the 10 languages. You would just click on that and it would download it all for you, so that you could provide your patients or community members with the specific languages that they need. So these are just a quick example of our cancer screening toolkit as well. They're available at the booth. If you want to order them and you want to have them on hand in your office, you can just send us an email and then say that I need this many toolkit, and we can send this out to you as well. For cervical cancer screening resources, we do have a colposcopy wait time dashboard on our website. So a lot of the questions that we got asked is, what is the wait times if a primary care physician is referring into colposcopy? How long do I have to wait? This dashboard gives you as much of a view as we have of how long colposcopists are, what their current wait times are. We also have a HPV resource package. It's the red button there. So this is colposcopists. It gives you the link of all the colposcopists in the region. It gives you a draft memo for high-grade follow-up, an HPV test follow-up reminder, how to access your screening activity reports. It has an EMR template for high-grade lesions. It has a tear-off pad or poster and patient no-show templates as well. So all of these resources are there. These are things that we get asked about all of the time. We've developed it. All you have to do is go and download it as well. This is a quick look at the dashboard, so you can see who the colposcopists are in Mississauga, Halton, Central West, what languages they speak. It has their fax number and what their current wait time is for high grade or low grade as well. That's all I have just in terms of the resources available on our website, but I'm happy to answer any questions about any information that you might need from the Regional Cancer Program or anything that we can do to support your practice. If not, thank you so much for being here today. I just want to let you know that all of the slides that you reviewed today will be sent out. All of the recordings of the presentations will be available as well. And for everyone who attended, we'll also be doing you will be receiving your CME certifications of attendance as well. Are there any questions? Okay, so with that, we're just going to do our raffle. For those of you who visited the booths and engaged with the teams that were here. Just anyone? Okay. Nadia, I can't see the last name here. Is Nadia here? All right. Thank you. All right. Okay, thank you so much, everyone, for attending. Please fill out your evaluation forms so that we can know how to do this better in the future years. Thanks again.